Right, so you're in the clinic, you have some vitreous floaters, sudden onset of floaters in your vision. It looks as though the optometrist is just checking your pupil sizes there. Let's do it in each eye, looking for any anisocoria before reviewing the back of the eyes. It's important to do some pre-checks before dilating the pupils, having a good look at the fundi. So it looks as though the optometrist is now checking the pupil reactions to light, doing the direct and consensual, followed by a swinging flashlight test, looking for a relative afferent pupillary defect, which may be present, or partially present, in a retinal detachment. Now the light's coming from the lateral side. It may be that the optometrist is checking the openness of the anterior chamber, just ensuring it's safe to dilate the pupils. I was looking at that shadow cast against the iris from the light on the lateral sides there. And I'd assume the optometrist is going to check intraocular pressures again before dilating, having a little look if the pressures are okay. Looks as though he's using a minim, anaesthetic combined with fluorescein dye, and he's just going to set up the Perkins tonometer there, checking the dial, the headrest. Now with Perkins, I have to numb the eye because the probe touches the cornea just very delicately for a few seconds. The optometrist looks through the viewing portal, aligns the Myers accordingly, and then reads off the scale to determine what the pressures are at that particular moment of the day. And next up, looks as though we have an ophthalmoscope. Now the optometrist may be checking for any corneal staining using the cobalt blue light there, just to see if there's been any corneal staining following contact tonometry. It's a very good practice there. Now the next step for the optometrist should be to dilate the pupils. So let's have a look. So you have another minim here. So I'd assume we're going to use tropicamide. So one in the right eye, one in the left. You can visualise the floaters a little bit more with the lighter background there. It may be if the optometrist wants to achieve best possible dilation, could opt for a second drop of phenylephrine, 2.5%, one drop in each eye. Lower the lid, pop the drop at the bottom. Patient has a few blinks. But it looks as though the optometrist is just pinching the nasal bridge there. So the idea of this is to just block the drainage canal, the canaliculi, for the eyes to try and absorb as much of the drops as possible. So after about 20 to 30 minutes we should have a maximum possible dilation. So the optometrist is now setting up the head-mounted binocular indirect ophthalmoscope there. This is the method that he's going to use to review the back of the eyes. So now we can look for any retinal tears or detachment. So we have the light source. We have to adjust the distance between the two viewing portals. Want a nice binocular view, some good stereopsis. Okay, so the optometrist just be holding the high-powered lens in front of the eye, just looking at all the quadrants of the retina through a dilated pupil. Have a good field of view with dilation and this method of checking the back of the eyes. Probably the most common way to do this would be using the slit lamp and a Volk lens, but this is a good alternative method if there's no slit lamp. So the optometrist will be getting the patient to look in 8 directions of gaze: up, down, left, right, and the diagonal areas. Really looking as far out as possible to see whether these vitreous floaters have come about from a tear or detachment. It could just be that the patient hasn't had anything sinister occur. The patient could have had a posterior vitreous detachment. Probably likely the patient would be experiencing some kind of flashing lights in their vision, along with the floaters. We should also investigate whether the patient has experienced any physical trauma to the head that may have led to these floaters. So now he's using the red-free light. This allows the blood vessels to be visualised a little bit better, giving them a black appearance against the retina. Switching between the eyes there. Okay, so the patient will be looking up there. You can still see the vitreous floaters moving about. If it is a PVD the patient's experienced, then it's important to reassure the patient, but obviously to come back to the clinic if their symptoms worsen or if they develop any other symptoms associated with a retinal detachment or tear. So now we're on to the cobalt blue. Just having another look there. Switching between the eyes. Now if something sinister like a tear or retinal detachment was detected, then the optometrist has to make a referral to the eye hospital for ophthalmology attention, quite sharpish. So looks as though the test, the BIO test is completed. Okay, now sometimes you can better visualise floaters using the direct ophthalmoscope up close there. Okay, and asking the patient to look the 8 directions of gaze, both eyes, right and left, just to really get an idea of the amount and size of floaters that have appeared. Okay, just going out as far as you can and asking the patient to look as far out as possible. Okay, that's everything.